For decades, seeing a slight lift in the J point on an ECG, traditionally called early repolarization, was stamped as a benign normal variant. It was the classic athlete's heart marker. However, that view changed dramatically after landmark studies, notably by Heisagre in 2008, linked specific early repolarization patterns to an increased risk of idiopathic ventricular fibrillation and sudden cardiac death. Today, we don't view it as a single binary setting. Instead, it exists on a spectrum ranging from a completely harmless ECG quirk to early repolarization syndrome, a distinct, potentially malignant channelopathy. Distinguishing between a harmless normal variant and a dangerous pattern relies heavily on the morphology of the J wave, the specific leads involved, and the behavior of the ST segment. Malignant or high-risk features. ST segment slope. A horizontal or downsloping ST segment following the J point elevation is the strongest predictor of arrhythmic risk. Involvement of the inferior leads 2-3 AVF or global involvement infralateral carries a significantly higher risk than isolated lateral or anterior leads. A J point elevation greater than or equal to 0.2 mV, 2 mm on standard ECG scale. Noticeable changes in J wave amplitude, especially a dynamic increase followed by short coupled ventricular premature complexes. Benign or low risk features. ST segment slope. A rapidly upsloping ST segment that merges smoothly into a normal T wave. Isolated lateral V4 V6 1 AVL or early precordial leads, highly prevalent in young healthy athletes. Clinical differentiation. An ECG pattern alone does not establish early repolarization syndrome. The diagnosis of early repolarization syndrome requires a matching clinical history. Asymptomatic in early repolarization pattern. Syncope, aborted sudden cardiac arrest, or documented polymorphic VT or VF can occur in early repolarization syndrome. ECG prevalence 5 to 13% of the general population for early repolarization pattern, while it is exceedingly rare for early repolarization syndrome. Demographics. Often young male physically active or athletes for early repolarization pattern. Early repolarization syndrome can present at any age, strong male preponderance in malignant events. Management. Reassurance, no treatment or workup needed for early repolarization pattern alone. Aggressive intervention, ICD, isoproterenol, quinidine, etc. may be needed in early repolarization syndrome. Risk stratification. Because the early repolarization pattern is so common in the general population, the vast majority of people with this finding will never experience an adverse event. Prophylactic screening or treating asymptomatic individuals with isolated early repolarization pattern is not clinically indicated or recommended. An individual moves into a high-risk category demanding thorough evaluation if they have the early repolarization pattern phenotype combined with any of the following. Unexplained syncope, especially syncope occurring at rest or during sleep, which points towards a primary electrical issue rather than neurocardiogenic syncope. Family history. A strong family history of unexplained sudden cardiac death at a young age under 45 years of age. High risk morphology. The presence of an inferior high amplitude downsloping ST segment pattern. Early repolarization is a normal variant for the overwhelming majority of people. However, it becomes a dangerous syndrome if accompanied by high-risk ECG features, that is inferior leads, horizontal or downsloping ST segments, and a clinical or family history of syncope or cardiac arrest. For an asymptomatic patient with an incidental upsloping lateral early repolarization pattern, reassurance remains the correct evidence-based path. For the patient presenting with unexplained syncope and an inferior downsloping J wave, it warrants an immediate aggressive electrophysiology workup.